Well, good afternoon, ladies and gentlemen, and a warm welcome from Cape Town. It's a beautiful day over here, not a cloud in the sky, and a beautifully warm day. It's our first webinar of 2023, and for that reason, I'd like to thank the presenters, Ash, and also our sponsors for this magnificent presentation. This is Season 3, Episode 1, and for that reason, I'd like to start by saying our presenter today is Dr. Amy Wise, and she's a senior specialist gynecologist in the Rahima Musa Mother and Child Hospital, the University of Witwatersrand. With me, as you can see, is Professor Steve Jeffrey. And Steve, did you have a good holiday?
Excellent holiday. I've forgotten about it already, but thanks for asking. And what about you?
No, I didn't have a holiday, Steve. I'm an obstetrician. We work straight through. So for that reason, ladies and gentlemen, I'd like to say that the topic this afternoon is overcoming barriers to vaccination in pregnancy and the role of the OBGYN in advocating for vaccination. While you're all joining, and I see that many hundreds of people have logged on this afternoon, we have 5 panelists, and next week we have an update on the use of GLPs in the management of obesity in the female patient. And that's going to be presented by our old friend, Judith Carter. So without any further waste of time, a great big thank you to Sanofi and Fatima, who you can see in the corner over there. And we're going to ask Amy now to share our slides. Amy, can you share your slides, please? Hello, Amy.
I'm getting there.
Thank you. Would you mind, Amy, if we interrupt you, if we have any questions as we go along? Would you wish them to be taken at the end?
But however your talk normally works, I'm quite happy with either.
We'll certainly interrupt you along the way. We find that a lot of questions come in along the way, which are quite nice to field as we go along. So if you don't mind, we'll interrupt you a little bit.
That'll be fine.
Thanks so much.
We see we've got an audience, a wide-ranging audience. There's some people have logged on from Khartoum in the Sudan, and we have some people from Nairobi as well as many people from the rural areas of our country. So we look forward, Amy, to hearing overcoming barriers to vaccination in pregnancy and the role of the OBGYN in advocating for vaccination.
Thank you both very, very much for the warm welcome. It's really lovely to join you all this evening. And yeah, it's a good topic. I think it's a great topic. And thanks very much to Sanofi for sponsoring this evening. So just as a start, my disclaimer that the presentation is intended to facilitate continuing medical education, and the views expressed are my own and do not necessarily reflect the views of Sanofi. Sanofi does not recommend the use of its products in any manner inconsistent with that described in the local package insert. And before using any products, please refer to them. And then my disclosures are that I am a speaker for Sanofi and a member of SASO Council. So when I first heard the topic, this came to mind. We need our pom-poms out. Advocacy is about being enthusiastic, about going all out for our patients and really making sure that they understand our enthusiasm for the topic and the importance of a topic. So by the end of the talk this evening, I hope that you've all obtained a set of pom-poms and are ready for our patient. So we need to consider then.
Pom-poms are on him as we speak. Steve, take those.
Has he got his pom-poms? I'd like to see them waving. My camera's off, unfortunately, but no waving of pom-poms. I'm sure there's a gym outfit there somewhere too. Right. So the major factors affecting vaccination pregnancy, what we're focusing on this evening is in the top right there, the healthcare worker acceptance, which includes then our knowledge of the recommendations, vaccine access and storage, reimbursement, and a number of other things besides. So if we need to understand then the barriers to vaccination, we need to understand the reasons why, what might underlie that vaccine hesitancy. And the main barriers to vaccination pregnancy are concerns for side effects from the patient's side and often the lack of provider recommendation. So when I'm looking for information about this, one of the problems that you come across is that actually a lot of the information comes out of the high income areas. People in high income areas are less likely to agree that vaccines are safe compared to people in low income countries. Overall, most people around the world agree that vaccines are safe. 8 and 10, 79% strongly or somewhat agree that they are safe, while 7% strongly or somewhat disagree, 11% neither agree nor disagree, and 3% say they don't know or have no opinion. The graph highlights deeper pockets of doubt about the safety of vaccines in certain regions and demographic groups. It's rather maybe fiddly on the screen, but I've highlighted there Southern Africa specifically for us. For example, people in several higher income regions are among the least certain about vaccine safety. Only 72% of people in Northern America and 73% in Northern Europe agree that vaccines are safe, and that figure is as low as 59% in Western Europe heading towards Russia and 50% in Eastern Europe. 15% in Southern Africa disagree in some way. So this graph here, if you look at the y-axis, has got there that disagree that vaccines are effective, and going along the x is disagree that vaccines are safe. So up in the top left-hand corner there is Liberia, which doesn't really think that the vaccines are safe, but effective, but does agree that they are safe. So okay to take, but might not work. Whereas on the far right, you've got France, where they don't think it's safe, and they also don't think it's very effective. South Africa falls somewhere in those little blue dots in the middle. A lot of this comes around then where our trust is sitting with our scientists. So the columns in this graph come from Wellcome Global Monitor, and you've got those with a high level of trust in scientists, those with a medium level and low. And I've specifically focused on the upper middle income countries here, which is where South Africa still sits. We need to be careful of our position there, upper middle income. So it looks at the percentage of people who strongly agree or somewhat agree that vaccines are safe. So if you have a high level of trust in your scientists, more than 80% agree that they are safe, and then it drops progressively 74% and then down to 63% if you do not trust your scientists. So people who recently sought information about science are also less likely than those who did not to agree that vaccines are safe. So that person who's on the internet madly hunting through all the different websites and trying to see, is it safe, is it safe, is it safe? The fact that they do not trust the mainstream resources, which then are hopefully supported by good science, are then less likely to agree they are safe. People who trust a doctor or nurse more than any other source of information are also more likely to agree that vaccines are safe. Our general barriers to vaccination. We've got the misinterpretation of medical information, the myths, the difficult to understand medical jargon and information, as well as the media. So the first point ties in with the finding, so that first point I went through. So the medical information on vaccines may be misinterpreted deliberately or not. These various headings, if you look on the bottom left, it's from 2020. We've got one on from 2021 and 2022 through the COVID pandemic. And the site USA Today went through and fact-checked all the different myths that were occurring and around the COVID-19 vaccine, around does it cause infertility, miscarriage, menstrual changes. So media can both be for the good and the bad. It just depends obviously on what you decide to read. Media again here can impact the vaccine uptake. So the Japanese Ministry of Health, Labour and Welfare suspended proactive recommendations for HPV vaccine after unconfirmed reports arrived in the media that there were adverse events. And you can see across the 90s, they had a really, really good vaccine uptake for HPV. And then suddenly in 2000, it crashed after those reports appeared and the Japanese government decided to stop supporting it. I haven't got a slide to show what happened after that. Right, the common barriers to vaccination in pregnancy. So from the pregnant women themselves, they've got concerns about the safety, the side effects, the harm that might be caused, perceiving themselves not to be at risk of the disease. We saw that a lot during COVID. It's not going to affect me, I'm young, I'm healthy, but unfortunately pregnancy we know puts you at risk. Belief that the disease is not serious. Misconceptions that the vaccine causes disease, illness, death, or other negative outcomes, a fear of needles, and then no provider recommendation. The receipt of a healthcare provider's recommendation was the factor most frequently reported as a reason for vaccination among pregnant women. And then on the healthcare provider's side, a lack of knowledge and education, which is why we're here tonight, considered vaccination outside of their remit. It's not my job, not my scope of practice. We hear that fairly often. not enough time to get through to it, concerns about the vaccine safety and efficacy themselves, a perceived low risk of the disease. We see this especially with tetanus in South Africa, that it's not a disease that we're seeing now, but there are sporadic outbreaks. And of course, it then ignores the fact that we've done such a good job with tetanus. That's why we don't see it. So if we stop doing a good job with tetanus, we're going to have a flare again. Perceived lack of clinical trial data with vaccines in pregnant women, and then administrative difficulties, logistical issues around staff obtaining the vaccine, financial concerns. So this summary forest plot lists the factors associated with maternal vaccine uptake. Although the recommendation of a healthcare worker was a powerful tool to increase the uptake of maternal immunization, believing the potential for vaccine-induced harm had a negative impact on the seasonal and pandemic influenza vaccine uptake and decreased the odds of vaccination by 5-fold. So one needs to recognize women's concerns and fears and have enough in your own armory to be able to refute those things. So the role of the OBGYN. We have the most critical role in enabling vaccination in pregnancy. We have a close relationship with our patients. We are their most trusted source during their pregnancy, and therefore we should be discussing it at the very first visit. We must be well informed, and the team must agree on the benefits of vaccine in pregnancy. We teach our registrars all the time about the multidisciplinary approach. Well, that means everyone in your office, everyone who's going to have contact with the patient, the pediatrician, must all be singing from the same song sheet. Must fully appreciate the absence of harms and positive effects of vaccination in pregnancy on the woman's health and newborn child. That's a rather broad statement because, of course, we do know that there are some side effects, but in general, the message needs to be positive. All healthcare practitioners whom a woman may encounter during her pregnancy, they need to be educated. The vaccine importance and the strategies, it is worrying to look that obviously our vaccine programs target children. Children are always the focus of a lot of these things, and they have benefited the most with the decrease in disability and death. And so one then sees that 42,000 adults versus 300 children die each year from vaccine preventable illnesses in the US. And I think South Africa could probably see a similar sort of trend as well, and especially if you consider things like HPV and the scourge of CA cervix in this country. If one were to swap those figures around and had 42,000 children all dying from a vaccine preventable illness, there'd be an outcry. More than 50% of cases of significant vaccine-preventable illnesses reported to the CDC in 2004 occurred in individuals greater than 15 years. And that's usually when people have aged out of that sort of EPI program that you're then going to start, unfortunately, getting those illnesses. Many of the most vulnerable adults are seen in practices that provide healthcare to women. And so these are the people that we should be targeting. Vaccination services have also, unfortunately, not historically been part of OBGYN care. We need to communicate benefits and harms in a clear and understandable manner. This is a poster from the Society for Maternal and Fetal Medicine talking about influenza, pertussis, and COVID-19. To that, I would add tetanus myself. We also need to complement that clinical advice with data highlighting the risks of the disease and the benefit of vaccination. Here, this poster then telling us about the 60% reduced risk of COVID-19 hospitalization babies younger than 6 months old. There are many resources out there which you can then go and find. This poster is in from the Northern Hemisphere, so not so useful down here, talking about the flu vaccine that is available in the winter months across there. But there are equally resources available here to put up in your room. So this systematic review also then, as part of the educating of your patients, is to point out that the vaccination helps to prevent influenza cases and hospitalization in infants less than 6 months old, leading to a 48% decrease in the risk of influenza. No mother wants to see her child in hospital. Horrible time to have a baby in a hospital with something like influenza on oxygen. 72% decrease is also seen in the risk of hospitalization. Are we the barriers to vaccination during pregnancy? 22% from this study, now this is an old study, back in 2001, it was reported in the Journal of Reproductive Medicine. 22% reported discussing the flu vaccine with their doctors back then. Only 8% were vaccinated. However, more physicians said they had discussed vaccination with their patients than the patients said it was discussed. So obviously there was a miscommunication somewhere. Sometimes what you might briefly mention and feel that this was fully discussed has only come across as very glancing. And if we're not going to put enough emphasis upon it, the patient is not going to see the relevance or see it as being as important. Physicians were also more likely to vaccinate if they're aware of the CDC guidelines, if they gave the vaccinations in their office and had received the flu vaccine themselves. So gaps in both of the groups' understanding of the benefits for influenza had an effect on the uptake. We need to use facts and positive messaging to dispel myths about vaccination and pregnancy. Things need to be clearly delineated for the patient so that they are not going to be confused. This is from the Philippines. It is again talking about tetanus, about receiving that first dose and then another dose a month later, which is the same as the South African guidelines, and then your last dose, the third one, which you might get in pregnancy, depending on when you joined your pregnancy into your antenatal care, might get a third dose in. So communicating efficiently is the key to building trust and moving forward when addressing doubts concerning vaccination. Corrective information is generally effective at reducing misperceptions, both for the misconception that influenza vaccine, for example, causes the flu, as well as misinformed concerns about its safety. One needs to emphasize the facts. Avoid repeating the myth. Reinforce the correct facts instead of repeating the myth when correcting people. It's not helpful, as all they really remember is the fact that you've again said to them that they might get a miscarriage because of it. Leave out the word miscarriage and just talk about the fact that it's going to be helping with the baby and preventing them being admitted. Less is more, and use simple responses. The strategies that can increase the uptake of vaccination in pregnancy in high-income countries. And again, I emphasize here, it says high income because there is so little information produced in the low-income countries. We need one-to-one information and education during antenatal appointments. And this worries me because often our counseling, certainly in our big clinics, is taking place where one person is talking to 130 people. And certainly it's not that one-to-one sort of interaction that you would like. One needs posters and information leaflets, information on safety, efficacy, when to offer and receive vaccination, the distribution of the information material in the antenatal care facilities, education sessions for staff, reminder alerts. So things like Moms Connect, for example, are very useful in terms of reminding people about vaccination and the importance of it. And then that midwives also, where in the clinics, for example, should be providing vaccination. A 2022 narrative synthesis aimed to define the most important barriers and facilitators for maternal immunization and to identify priority areas for future research in view of the future role of the RSV, rollout of the RSV and GBS vaccines. And the study was also done to look at barriers and facilitators to inform future policies. And the concerning thing here was that there was very little research coming from the low and middle income countries. If you look at the bottom of that graph there, really, really low numbers, whereas most of it is coming out of Asia, Central Asia, and North America.
Can I just ask you something?
Sure.
Accessibility of the vaccines to firstly in the state hospitals and also in private practice. Isn't cost potentially an issue? I don't think we've heard that discussion yet from your side. Is that something that is an issue, or are we now just talking where it is readily available?
Okay, so the provision, so National Department of Health guidelines still only really have tetanus and influenza, but even the amount of influenza vaccine that we've got is very low. So we only achieve about a 10% coverage rate was the last figure I heard when I was at the NICD in pregnant women across the flu season. And so we don't actually get enough doses of influenza vaccine in, as far as I know. Tetanus, we have very good coverage. And then pertussis, perhaps Fatima will have more information, but because it's not yet in our guidelines, we don't have, certainly in government, the buying power. We don't have the mandate yet to buy it and provide it. So I can suggest it to my patients in government, but then they've got to go source it and buy it. So access at the moment, certainly in our setting, is going to be a problem. Within the private setting, I've also heard of places where pertussis hasn't been available in certain of the pharmacies. But again, it's that thing of sensitizing the pharmacies to get it in. So if we create the demand, then hopefully they'll bring in the drug.
Amy, if I can just ask, the SASOC guidelines, you're on the SASOC Council. The SASOC guidelines, as I know, do recommend the third trimester immunization with Tdap, do they not?
Yeah, they've got Tdap in it, but remember your tetanus should be given also earlier. And you need to get 2 doses. So you need to get the tetanus toxoid by itself. Because a lot of these women, the assumption is if they haven't received anything for 10 years, you need to start again. So you need tetanus toxoid. Tdap helps, but then you need also that tetanus toxoid separately as well.
Okay. Thank
All right,
you.
so
Dr.
yeah,
De
there we
Jong,
go.
sorry, just
Yes,
maybe to
Fatima, please,
address
yeah.
the question in terms of TDAP. So unfortunately, TDAP is not yet available in the public sector. I think the National Advisory Group on Immunizations, they definitely see that need for it, especially, I'm sure maybe as you guys are in the Western Cape, so perhaps you've heard of the current pertussis outbreak in the Western Cape. And that's obviously where the need for TDAP comes in, is really to address that gap of maternal immunization. But it's not, as I said, it's not yet unfortunately available in the public sector. But we're really trying to say that if you are in the private sector, and you have access to the vaccine, really make use of this public health intervention.
Thank you.
Yeah, so
Amy?
here I just focused on one of the very few studies that was done in a lower middle income country. So this was in Sierra Leone, which has one of the world's worst maternal mortality rates. Well, has, I think, the world's worst maternal mortality rate, sitting up near 1,000 per 100,000 women. And this was looking at the prevalence of receiving tetanus toxoid immunization during a woman's last pregnancy. It was higher, 96.3%. And that of taking at least 2 doses was 82%, but they saw that the higher odds of receiving it was if you'd obviously booked well, so at least 4 ANC visits, if there was mass media exposure, and then obviously those in the higher wealth quintile, which unfortunately I suppose just means that you always have those same people who are less well off. So in terms of developing a local OBGYN action plan to enhance vaccination uptake in pregnancy, you need a multifaceted approach, recommendations by the OBGYN or midwives from the first visit, education and training for the healthcare practitioners involved in pregnancy management, education for patients via healthcare practitioners and through written materials and social media, provision of alerts and reminders by text messaging, written protocols. We need national, regional, local, and institutional guidelines, and then support from the local health administration teams to improve vaccine availability and administration, including of on-site provision of vaccines, and then governmental and community public health campaigns to improve awareness and financial support. So the predictors of vaccination in pregnancy and strategies to improve the uptake, the reasons which were provided for not routinely recommending vaccines to pregnant women by the professional categories. The 2 main reasons were the concern about potential side effects and the lack of experience. People are nervous about giving a vaccine. They haven't usually given it in their practice. They are going to be less likely to provide it. This was data out of Spain. So again, more of the kind of media that is available out there to show our patients. Right, so we need our pom-poms. So the questions you all need to be asking yourself is, are you promoting maternal vaccination within your practice? Are you providing accurate information? And can you answer concerns regarding safety? And can you explain the vaccine's effectiveness? I'm hoping by now you've all ordered your pom-poms. So have you got posters up? Have you got pamphlets available in your offices? Are you discussing it at each visit as a routine? Are you ensuring that the handheld notes have a place for record of vaccination? This is a problem. Frequently, if I receive patients out of the private sector, there are no handheld notes, there's no record of vaccination, and so then the patient is seen as being unvaccinated and they'll start again. Have you got enabled access within your own work environment, and is everyone in your work environment sensitized? Have you ensured that the vaccine is readily available and that it can be administered? Are you providing and attending CMEs such as this, and have you got the pre-prepared pamphlets from things like SASOG and the CDC? And these are more examples of them. As you mentioned earlier, here are the guidelines from the Better Obs website. So you can see there they've got in all of the vaccinations required before, during, and after pregnancy, and the influenza vaccine is specifically mentioned there before, during, any trimester, and after pregnancy, and the various other ones that we do have available. Notable is tetanus toxoid is actually not mentioned on here. They've just got the Tdap commented on. So we do have then the National Department of Health guidelines. The interpartum care guidelines are going to be updated. They're in the process of it. And these, this particular one was out of the 2020 EDL, showing where we should be giving all our tetanus toxoid doses. So then, why should we be doing all of this, and have we got the information for it? So I've just briefly gone through the diseases that we are trying to protect our babies from. So why is pertussis an important pathogen? If your patients ask you, 45% of under 5 deaths occur in the first few months of life, and you can see their low middle income countries account for 95% of the 16 million pertussis cases worldwide, and that's nearly 200,000 deaths in those under 5 years. At Prathani Barra, 2 important studies were done there, which helped define our local risk, along with the communiques from the NICD. And I think that's what Fatima was probably alluding to, that there's been a rise in cases. So in 2011, Nunes et al. Looked at the samples collected on those infants presenting with low respiratory tract symptoms and determined the prevalence of HIV as well in the exposed and unexposed infants. And you see those children under 6 months with respiratory symptoms. It was 5.8 per thousand infant months in HIV exposed versus 7.4 per thousand in those who are unexposed. Infants with respiratory symptoms, we certainly found a number of them, 2.3% had pertussis, and 86% of those are the children who are under 3 months. And that is because of that time of their lives where they do not yet have waning maternal immunity from the maternal immunoglobulins. And so we really need to focus on those babies. Right, so the vaccine effectiveness. In 2011, there was a pertussis outbreak in the UK, and acellular pertussis was offered to all pregnant women. There was 60% coverage at the time, and the pertussis incidence fell from a peak of 17.6 per 100,000 in 2012 to 8.6 per 100,000 in 2013. US data has also shown that there's a lower risk of hospitalization, shorter stays, and a lower chance of ICU admission compared with infants born to unvaccinated mothers. Unadjusted and adjusted vaccine effectiveness for preventing hospitalization among infants with pertussis was 72% and 58% respectively. And no infants born to vaccinated mothers ever required intubation or died of pertussis. The safety of Tdap vaccination in pregnancy. The randomized controlled trials of women who received Tdap vaccination during pregnancy found that there were no serious vaccine-related adverse events in the mother and infant. And the post-implementation of Tdap in pregnancy in the UK, there was no increased risk of stillbirth, maternal or neonatal death, preeclampsia, or any other predefined conditions. The US data also showed that there was no increased risk for SGA, prematurity, and hypertensive disorders. There was a small relative risk increase of chorioamnionitis, but then later on the vaccine adverse event reporting system, this was not repeated. Our annual burden of disease then for influenza, this would be our other big focus when we're looking at our women and we're vaccinating them. The annual influenza epidemics, we have 3 to 5 million cases of severe illness a year, and 290,000 to 650,000 deaths globally. In South Africa, 14% of inpatients with a lower respiratory tract infection have influenza, as well as those with influenza-like illnesses. Among severe non-fatal illness, there was 1,550.9 per 100,000 individuals, and the deaths were 80.3 per 100,000 in those under a year. There were 646 to 1,400 odd influenza-associated deaths in women of childbearing age in South Africa in recent years, a relative risk of 2.8 when you compared pregnant to non-pregnant women. So it is an important factor for our women to consider when they're trying to decide about vaccination. 90% of those were HIV positive. The vaccine effectiveness, efficacy for influenza, the pooled analysis of 3 trials. A lot of it came from our side as well, Nepal, Mali, and South Africa. There were over 10,000 participants. The vaccine efficacy in infants waned over time, but was 56% in those children under 2 months, which is really important. The vaccine efficacy then in the mums postpartum was 50%. So if we can protect our mums as well, then they're less likely to pass it on to the children. And that also then has a sort of cocooning effect for them. There is no overall association between influenza immunization in pregnancy and various adverse infant outcomes. You can see I went through all of them there: low birth weight, stillbirth, preterm birth, SGA, and infant growth. There was no significance for any of them. So the influenza vaccine does not cause harm. In terms of our guidelines, the NICD for the last set of guidelines was actually affected by the COVID epidemic. You can see there that the priorities changed and pregnant women were moved to the bottom of the list. So this guideline has yet to be updated again. So I don't yet know if pregnant women are going to be shuffled up to the top. Obviously, with COVID around, we wanted to try and protect the healthcare workers and certainly those people over the age of 65. But that said, pregnant women are still very much so on that list. And so when the influenza vaccine becomes available in the next month or two, I would strongly suggest we get our patients to use it. Right, neonatal tetanus, while it is rarely seen, and South Africa is supposed to have eliminated it, it is not strictly true, since it is defined as less than 1 case per live birth per district per year. 2 cases were reported to the NICD last year, since it was a notifiable condition, and both were related to unhygienic court practices, and cases involving skin infections and minor trauma are also reported occasionally. I certainly have heard of a few in the Baragwanath ICU. So we do need to continue to vaccinate our moms and protect our babies from tetanus. In terms of using the 2 drugs together, the Tdap and the tetanus, they looked at a retrospective cohort of 29,000 pregnant women between 2007 and 2013, and where they had the vaccines administered in close intervals from prior tetanus-containing vaccinations. It was not associated with any acute adverse events in the mother and no adverse birth outcomes in the neonate. Last of our vaccines that we need to consider is COVID-19. This data is from 2021. We're waiting for some updated figures. The maternal case fatality rate overall for COVID-19 was 4.5%, which was then 0.1% with all pregnant women. Perinatal mortality rate was 70.6 per thousand with the births, whereas we normally have it at around 30.8 per thousand for the country. Our cesarean section rate also doubled during that COVID-19 time for those patients affected. And we also saw a doubling of the hypertensive disorders in pregnancy in that COVID-19 population. And then the maternal vaccine effectiveness during pregnancy, there was a reduction if the mother took it of SARS-CoV-2 infection, an odds ratio of 0.46, and COVID-19 related hospitalization with an effect greater in fully vaccinated women. The risk of getting an infection was lowered, an odds ratio of 0.31, hospitalization lowered, odds ratio of 0.15. And although the certainty of evidence, they did say, was very low due to bias in the way that the data was collected, because you were collecting from this generally affected population. But there was also no statistically significant difference in maternal and fetal complications. In terms of the vaccine effectiveness in infants, with 2 maternal doses, your Delta infection, the Delta infection at 95% confidence interval, hospital admissions was 97% and 45%. With 3 maternal doses, the the vaccine effectiveness was sitting at 73%, and hospital admission, it protected at 80%. The vaccine effectiveness for infant Omicron infection was highest if you managed to give a dose back in the had given a second dose in the 3rd trimester. It decreased then from 57% down to 40% if it was given less than 8 weeks or more than 16 weeks before the delivery. So I do speak rather fast, apologies. Right, so I just wanted to get back to my slide with the pom-poms. I really do feel that this is an important topic that we need to be focusing on, both within the state sector with advocacy and really pressurizing those who are in charge to look at vaccines and trying to improve the availability of vaccination. And then within the private sector, and where your patients are able to afford it, I would ask that you promote vaccination and try to get women to see the benefits of it, both for themselves and their children. And then, of course, our visits for those who are down in Cape Town today.
Thank you so much, Amy. Amy, just before Steve thanks you, can I just ask Fatima, is Tdap or their equivalent covered by the medical aids in women that are pregnant?
Sure. So it's a very good question that you're asking. In terms of medical aid covers, it's always tricky. I mean, I'm sure for you guys that are always putting stuff through, you know how it is. Some medical aids uh, accept some things and some medical aids don't. So it really just depends on the medical aid. For a lot of them, so there's two options. So one is it can be covered from your chronic or from your risk benefit. So that means it doesn't come out of the patient's saving at all. And that's if you fall within, again, certain medical aids, and also if you fall within certain risk groups. And then for other medical aids, it will likely come out of your savings. So at the very
So
least,
there
it will come out of your savings. But I mean, essentially, for a lot of people, that's you can imagine pregnancy, you're claiming a lot of things. And so that does mean in a lot of instances that that is essentially a cash claim or paying cash. And some medical aids, though, do pay for it from your chronic risk benefit.
Okay, thank you very much. Then there's a question here from Habib M. Habib of Dar es Salaam. Why do we have rabies as a recommended vaccination option? Do we have lots of rabies in this country? I see it was mentioned under SASOG guidelines. Amy?
Sure. I haven't actually looked at the guideline.
Maybe
looking
I
at
can
rabies.
answer that one.
Yeah, go for it, Steph.
So it's not actually the rabies vaccine. It depends, I think, on your level of risk. So I'll have to double check the chart again. But from what I understand, is that again, it's kind of like a
It's not a
benefit.
routine.
Yeah, it's not a routine vaccination like
rabies
flu or
vaccine is that you're going to give it if you've been bitten and you're now at risk. It's more it's going to be one of those protective things. It's not going to be a routine.
Okay.
I don't think on that SASOG
So
guideline they're not talking about a routine thing for that rabies.
So Amy, maybe I can also comment. It's based on the severity of the outcome of rabies, right? So because the mortality is essentially 100% in a confirmed exposure or risk, we say that the rabies vaccine is not contraindicated in pregnancy, but it's definitely not indicated as routine administration in pregnancy.
No, it's really meant for those people who are at risk of actually contracting it.
The women veterinarians
by a dog or something.
So thanks so much for such a great talk. I mean, I think it still remains a challenge, it seems, and I think it's not easy in the state or in private practice. And I think one of the main challenges is really just getting the gynecologist to discuss this with their patients. Often they've got like a 15-20 minute booking visit, a lot to talk about, and I think vaccine just falls by the wayside. I mean, is that the main issue, Pete, or
well,
what
Steve,
do you think is the problem?
I see a lot of obstetric women, and what I do is that they seem to spend as much time talking to my receptionist as to talking to me. So I have a poster at the receptionist's office, and it says vaccinate, and the two ones obviously that we punting are the Tdap or the Sanofi equivalent, and also influenza.
So what do you do from a practical point of view? Do you keep it in your fridge, or do you give them a prescription, go down to the pharmacy and get it, or how do you?
I'm not a dispensing doctor, so I don't have a license to give vaccines, but I do have a license to put up a poster on my wall and on my receptionist's office that says, please vaccinate. This is a guideline from the CDC and SASOG that you should give, if nothing else, perhaps not rabies, but certainly influenza vaccination and also Tdap.
And how expensive are these vaccines?
Well, you can ask Fatima, but influenza is a couple of $100 and Tdap's about 370 as far as I know. That's what they say. So
you
it's
write
not
a script.
Well, yeah, that's the other thing, is that generally, if it's on the guideline, you should say, go down to the pharmacist and get your influenza. But you'd be surprised how often that they come back from the pharmacy and they say, where's your script? Now, maybe that's just for medical aids, but the pharmacists also need a bit of education over here, because when I say vaccinate in pregnancy, they think that you're saying something awful and something horrible. So we need to cast the net wider in terms of who we're educating for how to give it, who to give it, and who gives it. So that's part of our educational mandate.
So essentially,
do you not think writing the script helps actually the patient to see that you're serious, that you actually want them to take the medication, like just like you might write up your aspirin or your whatever else you're giving them, as opposed to leaving it to them to decide to wander down to the pharmacy?
Well, I do. I say, please remember that you need vaccination. If you wish to have a script, here's a script. Sometimes I have a lot of indigent patients, and it's also difficult for me to persuade them that vaccination at the cost of a couple of £100 is so important to them, whereas they could use that money then for transport or something else that they feel is important. You see, what are you were going to say something, Fatima?
No, I was just going to say it's important what you're saying about awareness at all levels, and that's something that we're also really trying to create. And at the same time, I would also really very much support Amy's point, because while we know all three vaccines, the Tdap vaccine, COVID, and influenza, none of them require prescription. And so technically the nurse or pharmacist who's even dispensing their iron tablets, whatever it is, could ask them, did you get a Tdap vaccine? There's an outbreak, or it would really help you to protect your baby. But what we find is that often the patients are really hesitant to take it, or they'll be like, oh, but my obstetrician or my gynae didn't really tell me about it. It's the first time I'm hearing about it, or they're really waiting for that vote of confidence from their doctor.
Yeah.
I
think that's why we have these CMEs. So the people that do log on can have, it's a bit like selling a drug. You hear once, but the rep has to come 3 or 4 times every 6 weeks just to persuade you, that to reinforce the options of either prescribing their drug or prescribing the vaccine. As you say, the prescription tends to carry more weight than if you say, nip down and get influenza vaccination.
But Pete, from my days of obstetrics, I remember, there's quite a lot to talk about in the first visit often, or the second visit. When do you think is a good time? I think the first visit, people are talking about the delivery, screening, there's multiple things that come up. Do you think it's the first? Do you think, how long can you leave it for? What would you?
Well, you saw that on Amy's slide in the middle of the talk about SASOC guidelines, better obs, when you should give it. So if you have that up, I can't remember exactly when to give everything. I know that you can give influenza anytime, and you should preferably at the beginning, because if you can give it during pregnancy, give it when they start getting pregnant, not when at the end, because of the dangers thereof, and we've seen. So if you had that thing to hand in a drawer, just like you have other things to hand in a drawer next to you that you refer to, because for example, there's certain drugs you only use now and then. For example, if a woman's got increased bile acids, Steve, what would you use to treat increased bile acids in pregnancy? I bet you don't have any idea.
I never clue.
Well, nor do I, but I have a little thing that says if a woman's got raised bile acids, then you have to give Splinky Splonky. So then you could say, now listen, let's get that.
What's the dose of Splinky Splonky?
What's the dose? It's actually 500 milligrams BD. So what you need to do is to have that guideline in your drawer, and so you can refer to it if you can't remember. But if you give it every time to every pregnant woman, sooner or later you will remember when to give and what to give.
My comment also, certainly in state we've got your maternity booklet, which is all very set out, and then depending on how you set up practice in private, I would hope then that you've got specific things that you discuss with your patients at certain visits. So like you say, maybe that first visit, depending on what gestation they book with you, you might be, focusing on other things, but then maybe at that point is where you hand them the material that you are comfortable with and ask them to then have a look at it, so that in time for their next visit, you can then reinforce and quickly go through, have you read that material? Did you see the information about vaccines? Can I prescribe it for you? And give yourself, because I think it's difficult to remember all the little fiddly things that we need to tell our patients, but I think if you compile yourself either your own antenatal card, whether it's electronic or paper-based, with reminders and alerts all the way through as to what things need to be discussed with your patient. And then you'll individualize it for your patients when you're going to discuss whatever, at certain points. But then things like vaccine then at least would be built into it as a bit of a fail-safe. And certainly I do think you should have a set of notes that you give to your patients about, their pregnancy in general, so that they can come back to you and have a chat about it.
Well, they book in private, they book very early, around about 20 minutes pregnancy. So the other stuff, it's called Ursofolk, incidentally. I could see you Googling desperately. So it's Ursofolk is what you give for raised bile acid. So
oxalic acid, yes.
I could never say that word. So just remember Ursofolk. So, Steve, Would you like to thank Amy
Yeah,
again?
thanks. Thanks, Amy. It's really been a great pleasure, and I think this is something that a lot of people don't think about. It's not discussed extensively, and certainly seems to make a difference to a lot of patients. So hopefully, talks like this will be done more regularly and raise awareness. And we certainly appreciate your time, and thanks to Sanofi for sponsoring and for the continued drive in this area, which is quite important.
Yeah.
Thanks so much. I think without further ado, what was anything else you wanted to bring up?
Yes, I just wanted to just remind you, thanks to Ash for setting everything up, as always, the indefatigable Ash. And then to remind you that next week is GLPs in the management of obesity in the woman. And that's presented by Dr. Judith Carter.
And we have to wait till next week to work out what a GLP is, because
you
didn't know and I didn't know at the beginning of the talk.
That stuff, it's like a drug you give for obesity, Steve.
Okay, we'll wait for next week.
You are needed.
Can help us.
I'll need it. So then, Fatima, if you could just wrap up finally, thank you, and then we play out with your video.
Oh, thank you very much as well for inviting me. It was really good to meet you both. Sorry about my video.
No problem.
What video?
Yeah, exactly. It's load shed. I don't know. It broke.
Thanks, Prof. Jeffrey and Dr. DeYoung again for the excellent opportunity. And as I always say, on behalf of the medical team as well, thanks Dr. Amy Wise and Ashley for giving up your Thursday, you can tell I'm already on the weekend, Thursday evening. And as the medical team, I always say that we're really trying to support medical education. And so if you feel that there is any gaps, today we spoke a lot about ensuring that there's pom-poms and awareness. And so if you feel that there is any gaps in terms of vaccination in pregnancy or certain aspects of knowledge that you feel like we could support with a little bit more awareness, please, I would like to encourage that you reach out to myself or any of my colleagues from the medical team that are here today. And just, I just have one final comment before we move on. And I think Amy spoke a lot about how to increase accessibility, and we spoke a bit about the private versus public sector and what's available. And I always say that right now we know we do have the flu vaccine and COVID vaccine available, and we should really try to increase uptake of that. So for example, I know Amy, it's interesting that you mentioned that there are that there was little flu doses supplied, when actually in public sector last year, I think we only used about 60% of the flu vaccines, specifically in the public sector. Essentially 40% of flu vaccines that were supplied to the public sector unfortunately had to be destroyed due to poor uptake. So we really, as much as we've gone a far way in terms of awareness and advocacy, I think there's still some leeway to go. And thanks again for your evening, and please do reach out to us if you have any further questions.
Thank you very much. I think we can play the video now. We've got a video to play. So thanks so much for joining, and safe home.
Thanks for your use.
We say to ourselves,
what if we had the possibility to change people's lives?
Well, we do.
With both my personal life and my professional life being so full of hemophilia, I feel the need to pay it forward.
Do we stumble?
Sometimes.
Does that scare us? Absolutely not. It fuels us to chase the discoveries that light up our faces.
Imagining the impossible, that takes us places. Sports and science aren't all that different. They're motivated by the same thing. They're motivated by results.
We pursue little wins and learn from our fails and find different ways
of creating things together.
We chase the science that moves in directions
we never thought we'd see.
Science is ever-changing.
We're all driven by the same purpose.
Science is so intriguing because there's so much we don't understand, and that's what drives us to try to cure diseases.
In the end, it all comes together, revealing something bigger, bolder, brighter.
Something that changes things forever.
And when that happens, goosebumps.
As a scientist developing drugs in the clinic, when you hear a patient's story about how it really changed their lives, that's one of the most rewarding parts of the job.
I wasn't recording that.